It's my great pleasure to invite Mr. Kamal Shah, co-founder of Nephroplus, one of the biggest dialysis companies in our region. This lecture series is to try and foster a spirit of innovation and entrepreneurship among our learners at SSMC. And the title of Mr. Shah's talk is Building a Healthcare Organization in a Resource-Constrained Settings. Thank you, Mr. Shah, for this presentation. And I'm begin sharing the slides. And please, you can please start. Thank you very much for your time again.
Thank you so much, Dr. Anwar, and thank you to the entire SSMC team. Thanks so much for all those who've joined today, and it's really a privilege for me to be able to do this. So I spoke to Dr. Anwar, and there are a few objectives that we have set for this session, and I hope we're able to cover those objectives. Please go to the next slide, Doctor. So the objectives primarily would be these four. We are going to be focusing on resource constrained settings where the entire healthcare ecosystem and pretty much the entire country is very, very differently placed compared to some of the developed countries like the ones that you are based out of. We would be talking about the challenges that potentially people would face while setting up a healthcare organization and what the possible solutions were. And again, I will be talking a lot from my personal journey, the company that we built here, Nephroplus, a lot of these challenges that we faced here and how we overcame each one of them. The second thing which I would like to focus on is the importance of culture in a healthcare company. Healthcare companies, as I'm sure all of us understand, are very different from your traditional rest of the economy companies, and we need to understand that culture is a very, very important aspect of any healthcare company. We'll also talk about patient centricity, and that's a hot topic being talked about these days in the medical community. And Dr. Anwar also requested that I talk a little bit about how we can develop leadership skills and managerial skills. So broadly, these are the four objectives that we will try to cover in this session, and we'll open it up for Q&A once I've gone through my talk. Next slide, please. Just to give you a little bit of context about myself, I've been on dialysis for the last 26 years. I was diagnosed with an ultra-rare disease at the age of 21. The disease was called atypical hemolytic uremic syndrome, which is something that affects only 2 to 3 per million people across the world. I was put on hemodialysis for a year and a half, underwent a kidney transplant where my mother donated a kidney. Unfortunately, there was recurrence of HUS after the kidney transplant almost immediately, and I was back on dialysis. I did another type of dialysis called peritoneal dialysis for about 6 years after that. I was caught in a tsunami of December 2004. I'm not sure if people attending this call remember that tsunami. It was one of the fiercest tsunamis in the world, and I was actually at a beach, had a miraculous escape. Had to give up peritoneal dialysis as a result of some infections after that incident, and then switched to home hemodialysis, which is the same hemodialysis treatment that is done at hospitals or in dialysis centers, but the treatment is done at home, and it's done over longer durations, 7.5 hours each night for about 5 to 6 nights a week. And that is supposed to give a very good quality of life. I started writing about my entire journey, about the various therapies I had been on, and the challenges that I faced, and how I recovered from each one of them. Next slide, please. That blog became fairly popular, and at one point, if you would Google dialysis in India, my blog would come out right on top. In August 2009, I got an email from somebody I had never met or heard of before called Vikram Gupala. He was a healthcare strategy consultant who had returned from the US and were looking to start something in healthcare, and he stumbled upon my blog while researching on dialysis, and he sent me an email, and we started talking about the problems faced by dialysis patients in India and how we could set up a different dialysis company where we would put the patient right at the center of the universe. And we decided to call the company Nephroplus. One very important decision that we took during the early days of the company was that we would call our patients guests and not patients. So in India, there is a culture of a guest being treated equivalent to God, and we wanted all our patients to be treated very well, very welcome, with a lot of care and love in our centers. So we believe that terminology is a very important difference that we bring in our day-to-day operations. Next slide, please. So jumping right from there, 2009 to 2023, 14 years down the line, we are now present in 4 countries. We are running 325 dialysis centers. We have almost 4,000 machines. We are operating in 200 cities, and we've done more than 10 million treatments, and we currently serve more than 22,000 patients on a regular basis, and we've served more than 250,000 dialysis patients so far in these last 14 years. And we partnered with some of India's top hospital chains like Wockhardt, Max, Medanta, and so on, Fortis. Next slide, please. So I think the context, like I mentioned, is very, very different from resource constrained settings when you compare it with countries, developed countries like much of the Middle East, the US, Europe, and so on. So I wanted to talk a little bit about what the challenges are in a resource constrained setting like India, and then through our journey in Nephroplus, how we overcame, how we tackled each of those challenges. And we'll talk about the lack of quality or the compromise often made by several healthcare providers and hospitals in resource constrained settings like India to control costs, because costs become very, very important to run a sustainable operation. There is also a huge dearth of trained and qualified staff, ethical staff as well. We typically have management team which has very little experience in delivering world-class healthcare in a consistent manner, day after day, week after week, month after month. And there is also a deep resistance to adoption of technology and digitization among the healthcare community in such settings. And another major problem that we also face is little or no government regulation in the space that we operate in. So we'll talk a little bit about each of these challenges and how Nephroplus has tried to overcome each of these challenges. Next slide, please. So the first and foremost thing, and this was the central premise of Nephroplus when we started, was that we would provide very good quality, world-class quality to our guests, and by that we hoped and assumed that our guests or our patients would get their life back. There is a misconception around dialysis among much of the developing world, at least. I'm not sure how it is in developed nations, but in the developing world, including India, a lot of people believe that once somebody gets onto dialysis, it is pretty much the end of life, or life is going to be short, it's going to be compromised, people cannot lead a completely normal life. Now, we at Nephroplus and I personally believe that that is not true. And I myself, despite being on dialysis for the last 26 plus years, I lead a completely normal life. I swim every morning. I work full time. I travel. I've undergone dialysis in a cruise in Alaska. I have traveled and done dialysis in almost 10 or 12 different countries. So I lead a completely normal life. And if you run into me on a street, you would never guess that I'm on dialysis. And we believe at Nephroplus that every dialysis patient can lead a completely normal life, provided, and that's the most important aspect, is that the quality of dialysis has to be excellent. That can enable a dialysis patient to get back their life. So the first thing that we decided, my founder Vikram and me, was that we would never ever compromise on the quality of dialysis that we provide to our patients or our guests. One major challenge that we faced in India was that there were no protocols when we started out. There were absolutely no guidelines, no protocols that were enforced or that dialysis providers, dialysis centers, clinics had to follow. So we had to come up with our own protocols. what we did is we brainstormed, we from our own experience, we also got some nephrologists on board. We spoke to the paramedical staff, the dialysis technicians, dialysis nurses, and we came up with a set of protocols that were apt for our kind of situation, our kind of setting. So while these protocols were not enforced by the government, we decided that we would make sure that all our centers would follow these protocols. Now, that was a very, very key part of the whole offering, because if we made sure all our centers followed good quality protocols and provided good quality dialysis to our patients, then we would make sure that patients liked our service, they were happy with our service, they got their life back, which is the end goal of dialysis. They got their life back when they came for dialysis to a Nephroplus center. So these protocols are something which we took very seriously. Another thing that we also do is protocols are updated on an annual basis. We have a annual meeting of all the clinical quality team where there is an intensive brainstorming exercise on what protocols need to be changed, what can be made more current with what the more recent advances have been in the area of dialysis and nephrology. So this is not a stagnant protocol list that is there. It is an ever evolving annually modified and updated set of protocols. The next thing that we had to do was to train our staff, and I'll come to the challenges on the healthcare staff in particular in a little bit, but training was something that we absolutely had to do because most of our clinical staff were not trained in these protocols. A lot of these protocols were something that they had never encountered in their career until then. And the third thing that we made sure was we had an elaborate clinical quality team. Each quality manager was assigned about 8 to 10 clinics, and they would have to make monthly visits to these clinics and not only train the staff on these protocols, but also audit and check whether these protocols were being implemented in our centers the right way. Because we realized that it's not enough just to have protocols. You need to first train the staff and you need to audit the clinics to make sure that those protocols were being followed. One good thing that we did was we linked the score of an audit to the clinical teammates performance-based salary. So there's a variable component, and I'll talk a little bit in more detail in future slides, but there's a variable component that gets picked directly from the audit score that that center has achieved in that particular month. Another important thing to keep in mind is that a lot of protocols exist in the developed world. For example, in the International Society of Nephrology, you would have a certain set of guidelines that are recommended to be used in dialysis set clinics, but unfortunately, a lot of those protocols may not be applicable to resource constrained settings. Just to give you a small example, there is a process called priming that needs to be done of a circuit of the dialysis of the artificial kidney and the bloodlines that connect the artificial kidney to the patient. So this entire circuit has to be primed with saline to remove the air that can exist in that circuit. So now the saline volume that a lot of the protocols could indicate would be something like using 2.5 liters of saline per before you connect the patient. Now, what we realized is we searched a lot and we talked to several experts on what is the rationale for this number called 2.5 liters of saline. So we could not find any convincing answer on that volume. So we did our own study where we conducted a small kind of an academic study where we actually determined what is the volume of saline that could safely prime the lines before it would be connected to the patient, and we realized that that volume is 1.5 liters. So we switched to that protocol, and after switching, we've never had any issues. So the point I'm trying to make is not every single protocol that is designed for the developed world is actually suitable for the developing world. We may need to adapt without compromising clinical quality. We may be able to adapt and make sure that there is no wastage because in the resource constrained setting, these kind of challenges become very, very huge. Next slide, please. Healthcare workers was one thing that we faced and continue to face challenges on a regular basis from time to time. So when Nephroplus started our operations, for the first couple of centers, 2-3 centers, we were able to find good, qualified and trained healthcare workers. It was a challenge. We had to look really hard and we had to do a lot of interviews before we actually decided on an individual. But as we grew beyond 3-4 centers, right, when we reached 8 centers, 10 centers, 15 centers, 20 centers, we found that it was becoming increasingly difficult to get well qualified and well trained dialysis workers, or even in this applies to much of the other verticals as well. But we were finding it very difficult to find good quality healthcare workers. So what we decided was, if we are not able to find these kind of workers, why not train them ourselves? Why not we create them ourselves? So we set up a dialysis academy called NPDA, where we would hire freshers from the market who had a basic life sciences background, and then we would train these people the right way by giving them a solid theoretical background, a solid theoretical training, and then training them on the practical aspects of dialysis. Unfortunately, a lot of the training that happens in India, and I'm sure much of the developing world and resource constrained settings around the world, is that most of these people are picked off schools and colleges and put directly into the center without understanding what they are doing, without understanding the science behind it. They are directly just taught about dialysis and other healthcare procedures just from a practical viewpoint. So just to give you an example, many dialysis patients can have hypotension during dialysis or muscle cramps during dialysis. Now, technicians typically in these kind of places which are not done the right way would just be taught that if the patient has this symptom, just infuse 100 ml of saline. If the patient has cramps, do this. There is no theoretical background given to them about why you should do that and what exactly is happening when a patient develops hypotension during dialysis. So in our training academy called NPDA, we train them the right way. We teach them the theory behind every single practical aspect of the dialysis treatment. That gives them a much more solid foundation to be able to do a much better job when they actually go out there and start working in dialysis centers. One very important aspect of the training at NPDA and indeed of working as a healthcare worker in a Nephroplus center is the practically unlimited scope for growth. So growth is something that we always encourage our staff, our workers to aspire to do, and we have a nice path for them to grow. So now, since we are growing beyond the country as well, a dialysis technician can not only grow to become, let's say, a quality manager, a cluster quality manager, a zonal quality manager, a country quality manager. They can also look after entire countries. They can, after 3 to 4 years or 5-6 years of experience, they can actually go and start training healthcare workers in other geographies. So growth path is something that healthcare workers really value. So that is something that should be given a lot of focus on, and we do that a lot. We also encourage and incentivize flexibility to travel and take on additional responsibilities. So since Nephroplus is a very widely distributed organization, we strongly believe that our teammates should be flexible to travel and take on additional responsibilities. So as we grow, now when we want to scale a healthcare organization, there is geography is going to be a very important part of this kind of a scaling up organization. So it is important that people who understand the culture of the organization, people who have become capable in a particular role within a particular geography, they could be invaluable resources to actually go and take this whole thing and replicate it in another geography. So we incentivize heavily people who are willing to travel. That's one thing that has really worked for us in healthcare workers growth. there are, when you look at a bunch of healthcare workers, there will always be a few which will have that extra spark, that hunger for growth, that hunger to learn, and that hunger to succeed. You need to identify those people. It's not that it's not something that you can learn in a textbook, but when you interact with such people, that spark will come, and you'll be able to identify it in a jiffy, because these people are just, they stand out from the rest of the crowd, and you should be very, very particular to be able to find these kind of people, nurture them within the organization, give them good salaries, give them good growth paths, and give them additional responsibility so that they also feel valued within the organization. I think you can hear me, Dr. Anwar?
I can hear you, doctor. Yeah.
Hello, Dr. Anwar, can you hear me?
Hello.
No, just go back one slide, please. Go back one slide.
Yes, I can hear you, doctor.
Hello.
I can. Can you hear us? Can you hear us?
Can you please go back one slide?
Yeah.
Yeah, thank you. So, like I was mentioning in the previous slide, we have a variable pay linked to the performance of the clinic on the clinical audit. So that is one important. I'm sorry, I got dropped for some reason. So coming back to that, so variable pay is linked to the audit score of that clinic for all the employees of that clinic. That way we incentivize the staff of that clinic to have a stake in the clinical performance of that clinic. And we have a strict up or out policy. Unless people are growing, they're typically not encouraged to continue with Nephroplus. Next slide, please. Yeah, now the second set of teammates that we have, which are the managerial teammates, right? So managerial teammates, I'm sure all of you are aware, are not the traditional healthcare workers, but folks who are managing and driving the strategy of the company, leading complete functions. So this team is a very, very critical part of the whole team, because they are the ones who will translate your vision into reality, right? So they will motivate the healthcare workers, they will drive the healthcare workers, and overall take the company in the right direction. So for managerial teammates, we make sure that a large part of the compensation is linked to the performance, and it is not fixed salaries. That's one good tool that I would encourage people who are starting out or entrepreneurs to make sure that a large part of the compensation is variable rather than fixed. Stock options is another way to excite management teammates. That way they feel that they're part owners of the company, and if the company does well, then they also stand to gain. So stock options is a huge thing these days. It is fairly easy and fairly straightforward and standardized to structure stock options for your managerial teammates. And the variable pay of management teammates is often linked to the company's AOP achievement. Now, AOP is an annual operating plan. This is something that the board of the company decides and signs off on at the beginning of the year, and says that this is the plan for the company for this year. At the end of this year, we need to be at these numbers, right? So the variable pay of this managerial team is often linked to the percentage achievement of the company of the annual operating plan. I hope that was clear enough. Annual targets, obviously, this is something that is come up, that is drafted at the beginning of each year, where each managerial teammate is given targets specific to his or her function. And OKRs is a methodology that we've recently adopted, which is objectives and key results, right? Objectives and key results. This is a very structured way of converting these annual targets into quarterly milestones so that everybody has clear visibility into what they need to achieve at the end of every quarter. So that way, the entire company is working towards the company's OKRs, which are divided into the OKRs for the individual functions and the individual managers. One thing that we have done with a lot of success is to involve the management team to be part of all major decisions. It is not that Vikram and I, who are the founders of the company, we just take all the decisions and then the management team is expected to fulfill them. We have a lot of brainstorming with the management team because these are very capable, very senior people who can actually add a lot of value to that discussion. So we make sure that we discuss every major decision as part of a team, and we come up with a joint decision that makes them feel very empowered, and that makes them feel as a part of the company that is driving that a part of the team that is driving the company. We've also traditionally been a very transparent company, so most of the times when let's say we are having a problem, we transparently talk to the team about the problem that we are having, and we work together to arrive at a solution for that problem. At the same time, when the company achieves something good, also we transparently share it with the entire team. We also offer managerial team flexibility in working hours and location. These days, especially COVID, the pandemic has shown that it is not really mandatory for every single individual to work out of an office together. So while there are occasions when we absolutely need to work together in person, but unless it is required, it is not mandatory for everybody to work a fixed set of hours and at the office. They're also given a lot of ownership and a lot of flexibility to take decisions within the realm of their function, because we believe they understand their function best. They have a lot of experience related to their function, so they are the best folks to take ownership and take decisions pertaining to their company. While the strategic direction of the company is set in consultation, but Vikram and I's our vision is what drives it. Within each function, we give them a lot of flexibility and a lot of ownership to take decisions on their own. Next slide, please. At Nephroplus, we've always believed that it is impossible to scale without technology. Today, we have a presence in 4 countries, in more than 200 locations, 325 dialysis centers. It is impossible for us to be able to achieve this kind of scale and to run this kind of an operation without using technology extensively. So what we've done is our entire operations runs on the cloud. We have a system that we have built from scratch. We use a lot of ready-made solutions as well. We use an ERP, which is an enterprise resources planning software from Microsoft. We use that for our basic financial accounting and operations. We have digitized a lot. While we are nowhere near complete, nowhere near perfection, we believe there is a lot that can be done in terms of technology. But we have done a significant amount of digitization where a lot of our paperwork. So for example, the dialysis case sheet that needs to be maintained, there is a set of parameters that need to be maintained for every dialysis session. That complete case sheet is on a tablet, on an Android tablet, where the team enters the data. Our investigations, the blood tests that are done by our guests, are actually scanned using a tablet photograph, and that is read and converted into data digitally, and it's sent back to our portal. We are also working with an AI and ML based company on how we can predict mortality. Apart from that, there is the basic operations completely is digitized. The clinical data is completely entered into our portal, which is cloud-based. So all our guest investigations, our prescriptions, any adverse events that have happened, the baseline information of the patient, any mortality that happens, all this data is entered into a portal, which makes it very easy for us to do clinical research. I'm sure in your kind of a setting, I'm pretty sure that you would have digitization of your entire clinical records, but even in a country like ours, that is very important, because it is just impossible for us to maintain any kind of clinical oversight without digitization. We also do a lot of automation where, just to give you an instance, the audits that I talked about. So when an audit happens, there are some non-compliances that are identified. Each non-compliance is automatically created into a ticket for the person who is responsible for that particular aspect, and then that ticket is followed through until closure. So several such flows have been put into place by which the whole process becomes less manual, more digitized, more automated, less human intervention, less errors. We also have integration. So, for example, we have a patient app, a mobile app, which integrates into our clinical data system and our operation system. So on the mobile app, the patient can, or the guest can see the complete billing history, they can see their complete investigation history, they can see their prescriptions, they can get alerts when they need to take a medicine, they can do video consults with their doctor, they can get tips on how to maintain their dialysis diet. So a lot of integration between these various pieces has been done to provide a seamless experience to our guests. All of this is entirely based on the cloud so that we don't have to rely on physical servers that exist in our office, which adds a lot of complexity in terms of how to manage them and so on. Next slide, please. One major problem in resource constrained settings and the developing world is the lack of regulations. Now, some people would in fact see this as a advantage and not as a problem, but honestly, when you look a little deep down, I think the lack of regulations can encourage a lot of fly-by-night unethical operators who, without any background or intention to provide good quality, can just set up a dialysis center and do dialysis for patients. Now, the outcomes of these centers, nobody is monitoring. Nobody is monitoring on the quality of dialysis that these centers provide. So the lack of regulation is a huge problem. What Nephroplus does is completely self-regulate. We make sure that all our centers follow the protocols that we have set out. And an important thing that we do is we continuously engage with the government to bring in regulations, to regulate the dialysis industry, to regulate the dialysis centers, to make sure that poor quality players are discouraged and that the people who are actually providing good quality players, they are encouraged. We are also coming up with an NABH. NABH is a accreditation for hospitals that exists in India. We are working with the government to come up with an equivalent of NABH, but for dialysis centers. Now, this helps in multiple ways. One is, there are two things actually. So one is the basic provision of dialysis. If you bring in these kind of regulations that ensures that any dialysis center that is operating in the country adheres to a certain set of minimum guidelines, minimum quality parameters, minimum publishing of outcomes, basic minimum requirements for a good operation of a dialysis center. First of all, you'll improve the quality of the ecosystem of the entire country, right? Because you will strongly discourage poor quality players who are not in this, from a good intent per se, and are there just to make money. You will encourage folks who are actually want to make a difference and want to provide good care. Secondly, there are the insurance, the private insurance and the government insurance sectors are growing rapidly in India. Government has gotten in a big way, and even the private insurance prevalence is increasing steadily. So by making sure that there are these kind of accreditations for dialysis centers also, you can ensure that there is at the very least a differential pricing where folks who follow a certain set of guidelines, a certain set of protocols, they are provided better reimbursements for dialysis sessions by the government or by the insurance companies compared to those who are there just to make a quick buck. So I strongly believe that the regulations is something that really helps everybody in the long run. Next slide, please. India, while on the map and politically it is one country, honestly, when you look a little under the skin, it is like multiple countries. Several states in India are very different from other states, and this is it can be quite a big challenge for healthcare providers. While the differences between state to state are cultural, there are also between state to state a large number of financial diversity. So, for example, just to give you, the dialysis price can vary from free in some states to 8,000 Indian rupees per treatment, right? And you have these kind of differences within a state and within the entire country as well. So it becomes very important to be able to cater to the different types of people. Now, to explain it a little more elaborately, in dialysis there is something called an artificial kidney or a dialyzer, right? Now, in resource constrained settings, under medical supervision and following protocols, you can actually reuse that artificial kidney or the dialyzer for the same patient from 8 to 10 times per artificial kidney or dialyzer, right? Now, that provides a huge cost saving for somebody who cannot afford dialysis. Now, just to give you some background, there are a lot of people in India who are recommended to get 3 treatments per week. But due to affordability problems, they barely get 1 or 2, right? So when you look at that kind of a problem where patients who need to pay out of pocket are actually skimping on the basic frequency of dialysis that they are asked to get in a particular week, this kind of a saving offers a huge benefit for those kind of patients who, by not having to pay for the dialyzer every single treatment and reusing that dialyzer under medically acceptable conditions where proper precautions and proper processes are followed, you can actually encourage the patients to get 3 times a week treatment, which is much better for them in terms of longevity and quality of life. Now, those are one kind of patients. At the other extreme, you have patients who choose to get hemodiafiltration, which is a more advanced type of dialysis, and they do that in the comfort of their home. So you have this huge, 2 extremes, and there's again a whole bunch of patients who are in the middle at various points of this line. So it is important for a company like Nephroplus to cater to both these segments and everybody in between. So what we have done is we have worked with the government to take part in their public-private partnership projects where the government, who does not have the wherewithal to actually provide dialysis treatment, can actually partner with a company like us and pay us for the treatment of the population, and we do the provision, right? So everybody wins. The government wins because they're able to provide quality healthcare to their citizens. The citizens win because they're getting quality dialysis without paying for it, and they're not able to afford it. And it works even for companies like Nephroplus because we are able to serve a much larger population that way. So we partner with several governments to offer free of cost dialysis, very good quality dialysis to these kind of patients. At the same time, we also offer home hemodialysis, where we take the machine and the water treatment plant to the patient's home and do dialysis so that they get the comfort of dialysis in their home, and they don't have any problems. So they prefer that we give them that whatever they want, we make sure that we are able to serve their needs. What is different about the various types of dialysis is only the frills. The clinical quality remains the same. The clinical protocols remain the same. The only difference is, whereas the first type of patient is getting it in a hospital setting, which is not fancy, it is clinically perfect, but there are no frills. And the second type of patient is getting it in the comfort of their homes, where they have their family sitting next to them, they watch TV, they are in the comfort of their home, they don't need to step out of their homes. So this huge diversity that exists in the Indian population, we try to bridge by providing the service appropriate, or the service that is requested by each part of the citizenry. Next slide, please. Culture is something that I strongly believe is very, very critical in a healthcare company. Peter Drucker is a famous management guru. I'm not sure if you all have heard of him, but for those who have, I'm sure you're aware that he's a management guru who teaches in the US. He made a very significant statement a few years back that says culture eats strategy for breakfast. What it means is, however much you strategize, however much MBAs and consultants you engage, and however fancy a strategy you create, at the end of the day, if you don't have a culture, it's no use. And at the same time, if you have a fantastic strategy, but if you're able to develop a culture within the organization, that can work many more, much better than just having a strategy. So basically, culture is something that we should never underestimate. What is culture? Culture, to explain it very simply, is the values that the teammates live and breathe. This is something that should pervade the entire organization. So to give you an example, if you ask me what is the culture of Nephroplus, I'll say the primary statement that talks about the culture of Nephroplus is that guest care comes first. So this is something that every single individual, we din it into their heads that for us, our guests are the most important. We would never compromise on the quality of dialysis to save costs, to cut corners, to make better numbers, to make better profit. We would never ever compromise on the quality of care that is given to our guests. And few other smaller aspects of our culture are frugality, nimbleness, and quick decision making. Now, these are things that should come out in the day-to-day work of every single teammate of the company. And while when you start your company, I'm not saying that these are the cultural attributes that you need to have, but you need to think through and come up with what statements or what words or phrases define the culture, or what words and phrases you want to define the culture of your company. So that is the importance of culture. I think is very important. We've had situations where people have left Nephroplus to join other organizations for higher salaries, but within a few months they came back because they just could not survive in that company because of the entire lack of focus on patient centricity, the guest care comes first philosophy. So I strongly recommend that whoever starts out on the journey of entrepreneurship and is about to start a company, spend significant amount of time on what cultural attributes you want your company to have. Next slide, please. I was at a conference in Sharjah a few years back. It was an ESKD summit where we were talking about how the ESKD treatment options could be made more appropriate to lower and middle income countries. So one of the speakers there made a very interesting remark. He said these days it is trendy to be patient centric. So that remark was interesting, but what was more interesting was the next speaker came and said he did not believe that it is trendy to be patient centric these days, but he believed it was trendy to talk about being patient centric these days. So on a lighter note, I think people love to talk about being patient centric, but I'm sure you folks at the SSMC are very patient centric and committed to patient centricity. But that's one thing that at Nephroplus we take great pride in, that we truly believe that the patient is the most important stakeholder. And that's something that should be a no-brainer for healthcare, right? Because we're all there to serve the patient. But unfortunately, a lot of this gets diluted, and then people are looking at all kinds of other aspects rather than patient centricity. But something so obvious as patient centricity is something that often gets ignored, and it can manifest in many ways. But I think some things that bother me are not involving patients in decisions pertaining to their health and imposing a treatment or path to treatment on a patient. Patient reported outcomes these days, we see a lot in many manuscripts in journals and so on. One interesting thing that I wanted to bring to your notice was there was a song study, which is called the song study, where they actually asked patients on what are the factors that they value in terms of outcomes. And very surprisingly, quality of life came out above survival, right? So, whereas in academic journals and studies involving doctors and researchers, mortality, survival, these are some of the many of the studies, this is given the most importance, but a lot of dialysis patients, for them, quality of life was more important than survival. So these kind of nuggets of insight can be got by engaging with patients, and I strongly recommend anybody in healthcare to make patient centricity a part of their thinking. Next slide, please. So now a lot of doctors, they are fantastic at what they do. They are amazing at the clinical insights they can deliver based on looking at the data and so on. But once you step above that and start managing teams and maybe become an entrepreneur one day and start your own hospital or your own company in the future, I think these leadership and managerial skills become equally, if not more important, because you will be spending a lot of your time on these kind of things rather than just looking at patients and diagnosing conditions. So some of the things that we have done successfully in developing leadership and managerial skills among our teammates is that we organically grow individuals. That is, we take them and then we give them additional responsibilities little by little, and we slowly increase their responsibilities so that they don't become overwhelmed, because some people sometimes they can just get burnt out if you load them with too much upfront. So growing leadership and managerial skills is always something that needs to be done in a slow and steady manner. Shadowing existing managers could be a very effective technique. If you put, like, to give you an example again from the Nephroplus experience, we have folks who manage clusters of centers. We take management trainees and put them to shadow these cluster managers so that they learn the ropes while on the job. Teaching skills such as spreadsheets, presentations, reading financial statements is something that could be very important. Case studies help a lot in this aspect. Ownership and decision making is very, very important, because we need to allow the leaders and the managers to make mistakes and back them up when they make mistakes rather than criticizing them. And use pilots. Set up a small, let's say you want to do some new project, pilot it in a much smaller scale and then see how the results are, and then grow that pilot. I think very briefly, I just wanted to touch upon this. Please, next slide, please. I think we're done. Okay, yeah, motivation. So in a company, in a healthcare company especially, things will never always go smoothly. There will always be problems. It's important to have a higher vision or a cause that the entire team is working towards. That provides that provides a lot of motivation when things are not going well. So that higher vision is something that I would strongly encourage you all to think about. There was one phase in Nephroplus where we found that things were kind of slipping in many of our centers. What we decided is to take a pause on the growth. We stopped signing new centers and we took almost a 6-month pause where we consolidated the entire operation, looked at the problems we were having, and fixed each one of those problems before getting back on. That period of consolidation really helped us to see what we were doing wrong and then take corrective action. And fundamentals, I think that we should never compromise. Like in our case, we said we would never compromise on the quality of dialysis. We continue to adhere to that today, and irrespective of the numbers, whatever happens, we would never compromise on that. That is a very important thing to motivate your team, when things are not going well. Like they say, nothing is permanent, and this too shall pass. Next slide, please. I think we're done. Okay, Dr. Siddiq Anwar asked me to speak about what the future holds, and I think we're running out of time, but very briefly, I strongly believe that the entire world is headed towards universal healthcare, because the cost of healthcare is rising and very few people can actually afford to spend out of pocket on healthcare. Much of the developed world is already has some universal healthcare in some form or manner, but whoever does not have will get there in the next 10 to 15 to 20 years. Technology is huge. We are all seeing the increasing prevalence of technology in our lives. AI and ML is becoming it's becoming huge these days, and in a lot of areas we see the increasing role of AI and ML. One important nuance to keep in mind on AI and ML is to differentiate the hype from the reality. A lot of people claim a lot of things can be done using AI and ML, but it's very important to actually see what can be done before getting carried away by buzzwords like AI and ML and Chat GPT and so on. And patient-centric care is never going to go out of fashion. I think whatever happens, however it happens, I think to keep the patient at the center of the universe is always going to be the right thing to do. Next slide, please. Yeah, I think we're done. I hope you all found the talk interesting. We can open it up for a few minutes of question and answers. Dr. Anwar?
Yes, thank you very much for this excellent talk. Actually, I think so. I had three questions which I wanted to put to you, and you answered them. One is to how to build high performance teams, and I think so. What you were mentioning was this performance, the reimbursement should be linked to outcomes, what do they deliver,
Absolutely.
and of course having OKR concepts is key. Then you mentioned how to motivate people, team when things are not going well. You address that and how to balance the competing needs of a diverse population. So if you could, if the audience could type in their questions they have. Doctor, if I could ask you a question. Of course, you work for doctors from all over India, and of course, you now in Saudi and Middle East and Central Asia. And you, of course, see senior doctors, doctors in mid-career like me, and junior doctors. What do you think compared to your other vertical you worked on in the software industry or other industries you work with? What do you think doctors are lacking in their training, and where do you think they should be focusing their energies on?
I think communicating with patients on better communication with the patient. Now again, I'm not, my experience is limited to India, and from what interactions I've had online and so on. I think better communication with the patients is something that is that I would really appreciate, and there are of course several doctors who do that in a very who do that very well. But there are a lot of doctors who don't have that conversation with the patients in terms of what the options are, and what are the pros and cons of each option, and then together along with the patient take the decision on the path forward. That is one thing. Communication with the patients is something definitely. But another thing is technology. Like, while many doctors they use apps for their personal life, I think to be able to use technology to in a collaborative manner rather than looking at it as something outlandish, to learn how technology can be used to better their own decision making, to use algorithms that may be available. I think these are a couple of things that come to mind, Dr. Anwar.
Yeah, and what things? I mean, obviously you are a patient. Of course, you have a unique perspective, but maybe your colleague Vikram, who came to healthcare space, like what did he say? Like what are the big challenges as a non practitioner, you see in our field, which is holding us back, say, compared to, say, fintech or fashion tech or e-commerce, which seems to be like years advanced compared to us, where we are in, like, at least for me, in dark ages.
Yeah, I think the ability to adapt to change, Dr. Anwar, that is something that we really lack. I think when you see the amount of changes that have come in, the way things happen, right, in much of the many other industries like fintech and so on, we in healthcare, I think we are still wedded to the old traditional way of doing things in many respects. While of course we have better diagnostic techniques and so on right now. I think being able to adapt these new technologies in a better manner, or being able to adapt for simple things like regular processes, like let's say just writing a case sheet, or those kind of things. I think that we've been traditionally a little slow to adapt is what I feel, and what probably Vikram feels as well.
Great, thank you. I don't see any questions, but unfortunately, this is not a kind of open forum where people can ask you directly. But I don't see a question. But I think your talk was amazing, actually. And as I mentioned to you before, largely our learnings have been learning from our seniors. And I was recently in Hopkins when I met my mentor, and I asked him, because he was in WashU before he moved to Hopkins, you taught me great medicine, but you didn't teach me how you built the fifth biggest transplant program in America at that time. So he said, I could not replicate that in Hopkins itself. So even his own learnings, he could not document what made him successful in WashU, why he could not translate his success in Hopkins. Because largely we're not taught product management. We're not taught end-to-end product management. So we just hit the walls and something gets done. The whole idea was to try and see to bring successful people like yourselves, so you can share some of these ideas. And I think a lot of themes you'd address: OKR concept, having skin in the game, being agile, being collaborative. I mean, I think a lot of these things which we are not taught in medical school, unfortunately, because the way I'm assessed right now is if I'm doing a good diagnosis and management.
Right.
But that could be done by even younger folks now, because the knowledge asymmetry is going away in healthcare. Thank you, Dr. Kamal. It was a beautiful talk, and I look forward being in touch in future. Thank you, and have a nice day.
Thank you so much for inviting me. Thank you.
Thank you. Bye-bye.
Bye.